Okay, so for this deep dive, we're really going to unpack cervical cancer screening and specifically all the kind of radical shifts we've seen in the guidelines over the last, decade or so.
Exactly. And it's so important because it's one of modern medicine's biggest success stories.
It really is a true public health triumph.
Absolutely.
Yep.
I mean, where you have organized screening in place, the drop in incidence and mortality is just huge.
We're talking something like an 80% decrease.
At least 80%, yeah.
It's massive. And I think the key thing for you to grasp here is that this isn't really about finding cancer.
No, not at all. It's about finding the precancerous changes. The lesions.
So you can stop the cancer before it even has a chance to start.
Precisely. And to really get how that works, you have to look at the cause, the etiology of the disease.
Which is pretty unique for a cancer, isn't it?
It's fascinating. I mean, nearly 100% of cervical cancer cases, they're all linked back to a persistent infection with HPV.
Human papillomavirus. And that link is just so incredibly strong.
It is the cause. And while the virus itself is common, it's really, just a couple of specific high-risk strains that we worry about.
Mostly HPV 16 and 18.
That's right. They account for something like 70% of all the cancers. But the key thing, the reason screening works so well, is the time window.
It takes a long time to develop.
A long time, often 5, even 10 years, to go from an abnormality to an invasive cancer. And that's the exact window we're designed to intercept.
So that brings us to how we actually prevent it. There are sort of two main strategies, right? The shield and the screen.
A great way to put it. So primary prevention, the shield, that's the HPV vaccine.
Which is just an incredible tool.
Oh, it's the single most impactful strategy we have. The current one, the 9-valent, it can cut cervical cancer risk by 90%.
90%. That's if it's given in adolescence, before exposure.
That's the key, yes. Then you have secondary prevention, the screen.
And this is where things have really been changing, moving away from the classic Pap test.
Right. The Pap test looks for the effect of the virus on the cells.
But the new thinking is to look for the cause itself.
Exactly. The primary HPV test.
Yeah.
It looks directly for the DNA of that high-risk virus. It's just a superior test.
And how much superior are we talking here?
Well, the data shows it gives you about 60 to 70% greater protection against invasive cancer than the Pap test alone.
Which is why the guidelines can now safely recommend these much longer screening intervals, 5 years instead of 3.
That's the logic. If that high-risk virus isn't there, your chance of developing cancer in the next 5 years is incredibly, incredibly low. It's just very safe.
Okay, but this is where it gets a little complicated because not everyone agrees on the best way to screen. There's this big debate.
There really is. You've got the U.S. Preventive Services Task Force, the USPSTF, and ACOG.
The main OBGYN group.
Right. They're saying start Pap screening at age 21.
But then the American Cancer Society, the ACS, comes in with a totally different recommendation.
A very different one. They say wait until age 25 and start with the primary HPV test instead.
So why the delay? Why wait until 25?
It all comes down to avoiding harm. In younger women, under 25, these HPV infections, they almost always clear up on their own.
So if you screen too early, you're just finding things that were going to go away anyway.
You're finding things that would resolve naturally. It leads to overdiagnosis and then
Overtreatment.
And that's not benign. Procedures to remove those abnormal cells, like a LEAP or a conardization, they actually carry real risks. There's a documented increase in the risk of preterm birth in later pregnancies.
So you're potentially creating a future problem to solve what was likely just a temporary one.
Exactly. And if we kind of zoom out from the clinical guidelines and look at the bigger picture,
Yeah.
the real issue isn't what test to use or when to start.
What is it then?
The single biggest finding, the real bottleneck, is that the vast majority of cervical cancer cases today happen in women who have either never been screened
Or just haven't been screened in a very long time.
not in the past 5 years, yeah. That's where the system is failing.
So it's really an access problem. What are those barriers that are stopping people?
Well, they're complex. Some are structural. Things like the cost, not having insurance, not being able to get transportation or time off work.
The practical stuff.
But then there are also these deep cultural and psychological barriers. Things like stigma, fear, maybe a lack of knowledge, or even a real mistrust of the healthcare system.
And that disproportionately affects certain communities, right?
It does. We see it compounding inequities, particularly for Hispanic and Black women.
So to kind of wrap this all up, what's the big takeaway for you, the listener? I think it's that modern screening is incredibly safe. It's more effective than ever.
And it's less frequent, which is a good thing. The molecular technology is just that much better.
Right. The science is solid. The technology absolutely works.
Which means the biggest public health opportunity we have right now is, well, it's pretty clear. Since the tech is basically solved, the key to actually eliminating this cancer is to shift our entire focus.
Away from arguing about frequency for people who already get screened.
And onto access for those who don't.
So the final thought here is, we have this amazing public health triumph, this incredible technology. The real fight ahead isn't in the lab anymore. It's in dismantling those socioeconomic and structural barriers to make sure this triumph can actually reach everyone.